Hey guys, welcome to this lecture where I'm going to discuss how to assess and interpret the effect size. Things like relative risk, odds ratio, hazards ratio, and this is part of our series on summary statistics, specifically those inferential statistics, okay? Now, for proper and complete interpretation of effect size, it should be paired with topics on the p-value, 95% confidence intervals, which I've covered those topics previously if you need that background. And on that note, I'm Dr. Busti, your faculty and host on This Is Why, a show that helps healthcare professionals transform their medical knowledge from what to why, because when you know why you do what you do in the proper context of the evidence, it changes how. And that changes everything about patient-oriented decisions that we all need to make every day. Now, if you need a full list of the topics in this series, which I'm getting ready to cover where we're at in the outline, those are available for you on our YouTube channel, but specifically over at thisiswhy.health, okay? Especially if you're trying to do it through a progressive approach or you need that guidance. All these topics stand alone, right? Also, this topic typically follows the review of what is a p-value, what is a 95% confidence interval, 99% confidence interval, and what are they not, right? And so again, if you need that review, those are available on both YouTube and our podcast channels, okay? All right, so here's our outline. I'm just going to orient you. We're in part 2 still. Part 1 is before the study starts, where that's our statistical analysis plan, the things that you do before a researcher is supposed to start their study, right? Things about what type of data am I dealing with, nominal, ordinal, continuous? What type of study groups do I have? Are they independent or related? Considering what type of statistical analysis and type of data do I think I'm going to need, parametric, non-parametric analysis. And then if I plan to do inferential statistics, I need to consider alpha, our risk for making a type 1 error, power analysis, right? Our risk for avoiding making a type 2 error. And then part 2 is at the completion of the study, which is a lot of times what we're reading in the paper, obviously. What did the researcher or the author find? They do descriptive analysis and then the inferential analysis or statistics. And so we are in the inferential statistics section under effect size specifically, in this topic list, okay? Now, we need to do a little bit of background, foundation, perspective, okay? So we know where we're at in the overall outline of topics when we think about evidence-based medicine, biostatistics, clinical epidemiology. But what is this effect size and what does it tell us? What does it not always tell us, right? Well, this is a quantitative measure that gives us that magnitude of difference or the relationship that is being caused by either the thing that we're treating in the patient group or the exposure, okay? What does that difference make? We can say it kind of another way. How meaningful or practically significant are the results in the real world? Because that's what we care about, isn't it? So let's talk a moment about practical significance and its difference from statistical difference, okay? Significance. Remember, with statistical significance, we get a p-value. And that denotes that something is statistically significant or not, right? But assessing that effect size provides us with additional angles, perspectives that help us to determine if the results are practically relevant or significant in the real world, okay? Now, I want to add another little angle to this, right? Remember that statistical significance tells you if an effect exists. The effect size plus a 95% confidence intervals tells you how big, how precise or important is it now for your patients. Well, why does all this matter? Because you can have a very large sample size study, right? And it can find a tiny significant effect, but it's irrelevant clinically, practically, right? That's why it matters. So statistical significance can be influenced by the sample size, okay? And that's important. That makes it potentially misleading, which is what I just said. But the effect size, listen guys, the effect size is independent of the sample size because it's only using the data acquired, okay? And so that's why it matters. Now this section and this topic that I'm going over is going to focus on the odds ratio, relative risk, risk ratio, odds ratio, hazards ratio. I'm going to introduce number needed to treat, number needed to harm, okay? But know that there are other topics like Cohen's d, Pearson's correlation. Some of those are also blended in some of the other topics in the overall playlist or series. That's why I keep kind of referring people back. It's hard to obviously cover everything in its entirety without being overwhelming, all right? Now, that's our orientation. That's where we're at in the outline, in the series. That's what effect size, predominantly the context. Now we're going to start to dive into those individual measurements, those quantitative things that we're doing. All right, so what is now the difference? Because people throw these words around a lot, and they actually have different perspectives. And if used incorrectly, can give the perception of more meaningful results than actually exist. And so we have to be real careful as we interpret the literature. We also, as authors, researchers, want to convey it correctly, all right? So whether you're doing the research or you're interpreting the research, this stuff matters, okay? Now, risk versus odds. Now, risk is that probability, but it's, look at that bullet there. The number of times an event happens divided by the total people at risk. So that's the events divided by the total. And obviously that's just a mathematical formula, right? Numerator, denominator. The denominator is where the difference predominantly lies, okay? So if those numbers are the same, well, then the risk is 1, right? 2 divided by 2 is 1. And that would suggest there's no difference. And that becomes very relevant as we start thinking about confidence intervals in the overall interpretation of the data, okay? Again, I cover this in more detail in that 95% confidence intervals or that confidence intervals lecture that I do. So I'm just trying to bleed it in and integrate concepts where it matters, but trying to stay focused. But events divided by the total at risk, whereas odds are the number of events, okay, divided by the non-events, okay? So the denominator context is the difference, okay? So let's think of a clinical analogy scenario. Let's say you have 5 patients, they get intubated, and while they're on mechanical ventilation, one of them develops ventilator-associated pneumonia or VAP, all right? So what would the risk be from the risk perspective, knowing that the denominator is the total at risk, right? So that's 1 out of 5. So 1 divided by 5 or 20%. But the odds is different and the number is bigger. So remember, that's where we want big numbers, right? It's more dramatic. It's more exciting. But when you include VAP, remember, it's those that of non-event. So it's subtracting that 1 out of that group. So it's 1 divided by 4, 25%. And so that becomes really important in how we use what type of quantitative assessment of the magnitude of this effect in the type of study, because we'd rather be conservative at some level and err on the side of probably what's more realistic, okay, even though we're still estimating. Same thing happens when we do number needed to treat. You know, having a decimal point means nothing because you don't treat half of a patient or a quarter of a patient, right? So we round up or down depending on number needed to treat or number needed to harm to err on that side. So again, I'm just trying to lay a little bit of that groundwork. So let's now dive into risk, relative risk, okay? Now, this is, again, that risk of an event after some experimental treatment has been given as a percentage of the overall or original risk. So relative risk, risk ratio, RR, those things are all relatively the same, right? We typically calculate these for studies that are like cohort studies. Remember, cohort studies can be most commonly prospective, but they can also be retrospective in nature. They go forward in time. I know that seems counterintuitive or weird, but I cover that in the study design lecture if you need that. And then, of course, randomized controlled trials. So we calculate this in cohort and randomized controlled trials because we know the incidence, okay? So the denominators are known and complete. So we just think about the math. Again, numerator, denominator, the incidence rate of the exposed or patients who were treated, received the treatment, that was their exposure, versus the incidence rate of the non-exposed at-risk patients. Again, if those numbers are the same, it's 1, right? So that means that the incidence is the same for both groups. If the relative risk is greater than 1, well, then you know that the exposed group, whatever it was, okay, is higher, because the numerator has to be higher for that to happen than the denominator. If the incidence of the exposed group is smaller than the incidence of the non-exposed group, then it's less. Now, that number, above 1, less than 1, is always in the context of the exposure. What is it? Is that good or bad? Right? And so that's why you have to put in the rest of understand the endpoints and the hypotheses and the purpose of the study. But I'm going to walk you through some examples here, and I'm going to try to bring in and integrate other principles of biostatistical analysis that we've done in part 1 and part 2 of this series, okay? So let's say you take 2 groups of people, you randomize them, one group receives calcium channel blockers, the other group receives placebo. You follow them forward in time, and you're trying to figure out, do calcium channel blockers cause more edema than regular placebo? So again, you have 2 groups. I didn't say anything about crossing over. I said they randomly assigned to one of 2 groups. So those are 2 groups that seem to be independent. So 2 groups independent. What type of data are we dealing with? Is it nominal, ordinal, or continuous? Okay. Well, what's the endpoint? Did they develop edema or not? The question at the end of the study is yes or no. You can't kinda. You either did or you didn't. So yes or no, that would be binary nominal data, okay? That becomes very important, again, when you're trying to preemptively or post-study interpret what statistical analysis should you do, right? So again, we walked through those in other lectures, but I wanted to show you how that's done here, right? Now you need to calculate the incidence, because remember, relative risk is the incidence of the exposed group divided by the incidence of the unexposed group. So you take 110 divided by the total at risk, again, the formula, the total at risk. So 110 divided by 330, and that gives you an incidence of 0.33, 33%. Placebo, 80 divided by 330 gives you 0.24. So already just looking at the numbers, if you just stop right there and you only glance at the incidence, and you know the formulas, the incidence of the exposed divided by the incidence of the unexposed, right, placebo group, well, the top number of the numerator in the math is larger than the denominator. Well, I don't know, again, I don't have the math right just yet. I know you can see it on the slide if you're watching this on YouTube or videos. But you already know that it's over 1. I don't know how much over 1 until I do the actual math, but it's over 1. I can see that. There's an excess, right? There's an increase. So the relative risk is the incidence of the exposed divided by the incidence of the unexposed, and so it was 1.375. Now remember, 1 is no different. So the excess or reduction is the difference from 1. So the relative risk increase, RRI, some people use ERR, the excess relative risk is 37.5%. And you would say that there's a 37.5% relative risk increase in causing edema with the use of calcium channel blocker. That's how you interpret it. Those are what board exams love to ask you. They give you data like in this table, and then you end up having to answer that kind of choice. So you have to maybe do a step or two to get to that point, okay? What about relative risk reduction? Well, obviously, if I expose you to something, I intervene, then the incidence of that exposure must be a number that's smaller than those who were unexposed, okay? So that I'm getting a reduction. It's removing, it's taking away something from me, all right? And this is used to help make comparisons between the efficacy of the experimental treatment to the control that was being used. So we'll look at that example here. Again, they took a group of people, randomized them to one of two groups. You can receive aspirin to see if it prevents you from having a heart attack, or placebo. Again, two independent groups. The end of my study is whether or not I have a heart attack or not. So you either did or you didn't. You can't be in between, right? Yes or no. And so that's nominal data again, okay? So you think of your table on the statistical analysis that I review, that would be like a chi-squared analysis, okay? Again, you calculate the incidence. And so with risk, remember we're doing the total. So you have to know what the total population that was enrolled. And so that was exposed, the risk group. And so our incidence, you can see over on the far right, the aspirin group was 0.0126, placebo group was 0.0217. So again, the numerator is smaller than the denominator. So I know mathematically I should never pick an answer choice that is over 1 or 1. And so you might on an exam be able to get rid of that, right? But here's where it gets tricky. And this is where it's kind of like the excess or increased relative risk. When you do the math, you get 0.581. And so some people might jump to, oh, there's a 58% reduction. No. It's the difference from no difference, right? So what's the no difference? 1, because numerator, denominator, same number, they would be the same. That would be 1. So it's 1 minus 0.581, and that leaves you with 0.419. So there's approximately, approximate 42% relative risk reduction for having an MI by the use of aspirin. That's meaningful interpretation, but it's also appropriate in the context of effect size and its application. Now, when we think about some pearls as it relates to relative risk reduction, right? We always pair this with other things to help us, again, apply it to our real world scenarios. And that's where absolute risk reduction and things like number needed to treat come in, which is why I include it in this particular portion of the lecture. But you need to keep in mind that when the baseline risk is very low, and I kind of alluded to this earlier before, but I'm trying to repeat it so it sticks. But when the baseline risk is overall low, even an impressive sounding relative risk can actually be meaningfully very small in the real world. And that's why absolute risk reduction is something that I will many times in my lectures present, talk about, but you also need it in order to calculate the number needed to treat, which we'll see here in a minute. Okay? So this is the difference, the actual difference in the risk of outcome between patients who receive that treatment from those of another treatment group, usually the control group, okay? And it's usually provided as a percentage of those patients not experiencing, usually, an adverse outcome as a result of the exposure or the treatment that we are using. So let's take another example, right? This study randomized people to receive pravastatin versus placebo. They followed them forward in time to see if they, again, had a heart attack. What impact does lipid-lowering therapy have, okay? So you have the endpoint, yes or no, and you have the total. Again, many times they don't give you in a board exam tables like this real nice and clean. They may just give you numbers and they're telling you. And so you have to kind of orient yourself. Sometimes it's advised, if you're preparing for a board exam and you're using this content for that, to create these tables. If you're doing your own analysis, I think it's also helpful as an author researcher to create your table so you keep it organized and you don't make mistakes. But when you look at the actual control event rate versus the experimental rate, right, and you take the absolute difference between them, you get 0.03. So that's the absolute risk reduction. Okay? You use that to create your number needed to treat, which is basically the inverse, right? So 1 divided by the absolute risk reduction gives your number needed to treat. We'll see how that looks slightly different in context, I guess, mirrored for number needed to harm. But remember, we have a relative risk increase in that situation, or an absolute relative risk increase, right? So when you do that math, it says 33. Now remember, guys, when you do a number needed to treat, and I'm going to talk about this again later, there's context about a number needed to treat. It's the way the study was done, what was used, for how long. So you have to say, if you said to a patient, I would have to treat 33 patients for 4.9 years, because that's how long the study was, to prevent 1 MI or death from cardiac heart disease. That's how you interpret it. Well, for 5 years, up to 30, how much does that cost? Drugs for 33 people for almost 5 years, monitoring, labs, side effects, clinic visits, all the resources. That's what goes into understanding the application, especially in a public health scenario. What about that number needed to harm? Well, let's go back to our calcium channel blocker discussion. Remember, they developed edema. Usually that's not good, right? So there was a relative risk increase, or an excess relative risk of 37.5% in causing edema by using a calcium channel blocker. And we know that clinically is true, right? Now, what is the absolute risk increase, or ARI? Not ARR, absolute risk reduction, but absolute risk increase. Well, again, it's just the difference between those two numbers. And so it's 0.09. You take the reciprocal of that. 1 divided by ARI, which is, again, mirrored to the number needed to treat, and you get 11. So now you see that I have to treat 11 patients on a calcium channel blocker for one of these patients to develop edema, okay? So when we put number needed to treat, number needed to harm in the context of the real world, right, we do have to be very specific to the population being studied, the dose, the duration of the way it was studied, and the comparator, right? So there's a time frame component. The number needed to harm mirrors the number needed to treat. And when you're communicating with the patients, there's things that we talk about, which I'm talking about with number needed to treat, but then there's like, well, what does that mean to the patient? How do they like wrap their minds around all of this? They're not sitting there reading the paper like you, right? So you might say something like, for every 33 people that I treat that look like you, right, I have to do that for 5 years, treat 33 people like you for 5 years to prevent one of you from having a heart attack. And that helps them to, I guess, a layperson wrap their minds around it. Because that's one of the processes of evidence-based medicine, is that we apply it to our patient. Well, remember, evidence-based medicine, the Venn diagram, we integrate clinical expertise, the best available evidence, but also patient-specific issues. We have to be able to communicate that. And so that's why it's important. And many times you should consider the number needed to treat of other therapies that may also be available, because it may be that picking one over another is influenced by that perspective. Now, there's some additional pearls that I've already kind of alluded to. One is The number needed to treat, number needed to harm, that's a decimal or fraction, makes no sense. Okay, so what do we typically do, right? Well, if you have a number needed to treat, we go up to the next whole number, no matter what the decimal is. It's not 0.5 or greater, just 0.1. Just err on the side, right, of overestimating or this helps you to prevent from overstating the benefits, right? Because you have to treat more people. It sounds not as good, right? So you're erring on the side of that. Number needed to harm, you go down a whole number. And again, this prevents you from underestimating the potential harm. Again, those are great questions that show up, and it's kind of, you saw me get a little tongue-tied there in my own self, right? So it gets to be a little confusing. So make sure you have your mind wrapped around that. But that's what we do clinically. That's the appropriate thing. What about odds ratios? So remember, we were talking about that formula at the beginning, the total number of events, people exposed, and then that odds is different. That denominator looks different. It's the non-events at the denominator, not the total risk, right? So when are odds ratios used or many times done? It's mostly case-controlled studies, which are typically retrospective, and then logistic regression, which I cover in a separate lecture, regression analysis. So if you need that, again, go to that lecture. But those are the two places where odds ratios are primarily used, whereas remember, the relative risk is going to show up more in a prospective, usually cohort or randomized controlled trial, but there are retrospective cohort studies out there. And so why are these odds ratios reserved for case-controlled studies, okay? Remember, I told you the number can be different. I showed you an example of that. It can sound better, but people don't know what it means. They can take it out of context in the real world. So the investigator artificially determines that number of cases, the people with the disease. And this is in a case-controlled study, it's retrospective, as well as the people without, right? And because the researcher can set the denominator, you can't calculate the true prevalence or that true risk, okay? Now, what about the logistic regression? Again, I'm not trying to get in too much of the weeds of that. If you don't know what regression analysis is, again, I have another lecture on that, but in complex multivariable analysis, statisticians use logistic regression analysis to help control for multiple confounding variables that may influence the outcome that we don't want. We want to remove that influence mathematically, right? So these native mathematical output of the logistic ratio is an odds ratio. Now, I want to take one little step further and dive into this thing called adjusted odds ratio, okay? So remember, a standard 2x2 is just giving us a crude odds ratio, which is unadjusted, and I'm going to show you an example of that here in a minute, okay? That's the one I'm going to use. But regression analysis, again, is mathematically basically creating a level playing field, right? It's yielding to these adjustments and accounts for differences in baselines and characteristics between the two groups, right? Things like age, comorbidities, medication exposures, maybe their weight. Depends on what the study is, isn't it? But it's important to recognize that there is an adjusted odds ratio, okay? And so when we come back to odds ratios and relative risk, again, we're stepping back. We dove down just a little deep for a minute there. Now we're coming back out of the topic. And we're thinking about odds ratios and relative risk. And again, when the outcome of the thing that you're studying is very rare, usually less than 10% of the study population, then the odds ratio and the relative risk will actually start to look the same. Okay, so that's another important thing in interpretation. Okay, so the number of non-events is so close to the total that the math basically converges. Okay, now what happens when the outcome is rather common? Well, now the odds ratio and the relative risk start to diverge significantly, and that's where an odds ratio will always overstate the magnitude of the effect compared to a relative risk. I showed you that mathematically earlier, okay? So, for example here, if a study has an outcome and reports an odds ratio of 3.5, but the true relative risk might be 1.8. I mean, those numbers are very different. And so, again, it can be deceptive at times, or what I would consider slightly misleading if you use it outside of the proper context or without an author giving that context. Now, the author may assume that you know what you're talking about. You know how to read a paper. And that's why we do this, right? So how do you calculate an odds ratio? Okay, again, this is crude 2 by 2, right? So I put in here the treatment group. Those are exposed, unexposed. Is the disease present or is the disease absent? You create a 2 by 2. And a lot of ways that people look at this is how do you, what do you do with the data? And so I labeled each of these cells with the letter A, B, C, and D. And so there's a number of ways you can calculate it. I've circled or squared the common one. So A times D, right, which is, A times D divided by B times C. That is the most common applicable way to do it. I just list others that you might sometimes see. I think it creates confusion. I wish we'd just keep it all the same, but that is the one that most people are going to use. So let's apply it. So let's say you have patients who are using, unfortunately, cocaine. We know that that's a risk factor for drug-induced or cocaine-induced MIs, especially in younger patients that don't have atherosclerotic disease. And so if we're looking at the odds of that happening, right? So again, we're looking at that denominator difference. So cocaine users versus no cocaine users in the same population, those who had MI, those who didn't, right? And you look at the control group. So remember, those who didn't experience it. So when you do the math, A times D, B times C, you get 8.8. And what that means is cocaine users are 8 times more likely to have an MI. Okay, so again, it's that interpretation that makes it really important in the overall application. Now, what about when you have a time to an event or outcome? And that's where hazards ratios come in. Okay, again, ratio still having a numerator denominator, but now we're factoring in a treatment group versus a control group at a time frame perspective, right? So relative risk is at any given moment during the follow-up, right? But if you want that time adjusted where the outcomes are time to an event, death, like MI, stroke, reoccurrence of something, well, that's what hazards ratio does. It accounts for the time and also handles the patients who are censored, which means they were lost to follow-up, dropouts, event-free at the study end. Okay, well, relative risk treats everyone as if they had the same follow-up time. All right, now what about proportional hazards assumptions, right? Well, this assumes the ratio of risk between the two groups remains constant over time and over the entire study period, right? So if a drug works really well in the first month but fails after 6 months, then doing a single hazards ratio can be obviously misleading, right? I mean, I think that makes straightforward sense. So this highlights the importance of that visual kind of Kaplan-Meier survival kind of curves that show a time to event when you put it alongside the hazards ratio. And very much like a relative risk or risk ratio, if the numerator and denominator, even in that time interval perspective, is the same, then 1 means that it's no difference. Greater than 1 would increase usually harm, potentially a hazard, and then less than 1 is a removal or a benefit. Okay, and that's why we typically want to see those in the context of most studies that we talk about or use. I use this example here of the 4S trial, which was one of the trials with simvastatin, and their hazards ratio for all-cause mortality of 0.70. That's a 30% reduction in the hazard of death. Okay, and that's a way that you would see that being, again, removed from 1, the difference from 1. Okay. All right, so effect size and confidence intervals. I want to make a comment here, even though I said earlier I don't want to, try to bring in too many lectures and get in the weeds, but it's important to know that you can't only talk about effect size in isolation. That's why I said at the very beginning, it's typically paired with how to interpret a p-value. What does it mean? What does it mean? Not tell you. What is a confidence interval? How do you interpret it in the context of a risk ratio or odds ratio, right? So remember, the null value, the no difference, is 1. So if the confidence interval that you have, 95% or 99%, doesn't matter, if it passes through, and includes 1.00, the result cannot be statistically significant. I didn't say it can't have clinical meaning. It's not. That means the p-value is not going to be usually less than 0.05. Okay. What about your absolute differences, your absolute risk reduction, or your absolute risk increase? Remember, the null then value is 0. So if the 95% confidence interval crosses through and includes 0.0, then it cannot be. So it goes from a negative to a positive, right? It cannot have statistical significance. And so those become very important because a lot of board exams will want you to interpret data and maybe asking you, is this statistically significant? Remember, statistical significance, clinical significance, and relevance are 2 different things. P-values do not tell you clinical relevance. All right, wrapping this up, core concepts. Relative risk of 1, right? Incidence is the same. Numerator, denominator are the same. Greater than 1, numerator is larger than the denominator mathematically. You know it's going to be greater than 1, so there's an increased exposure, causes a greater incidence of the outcome. That may be good or bad. Relative risk less than 1, right? The exposure group has less of whatever the endpoint is. Absolute risk reduction is used in that number needed to treat. Absolute risk increase is used to calculate the number needed to harm. Remember, always put that relative risk in the context of the baseline risk. If it's really small, remember, it may be a big number in the relative risk, but it's not going to be very clinically real-world meaningful, right? Versus a 50%, okay? Confidence intervals, that helps you to give you a good estimate of a degree of uncertainty. And that's why we want tight, narrow intervals, okay? Number needed to harm mirrors number needed to treat, right? It's just the reciprocal of the absolute risk reduction or increase, depending on which perspective you're looking at. Don't confuse relative risk and odds ratios in common outcomes. Use them in the context of the proper study and what that baseline risk is so that you don't misinterpret or use those numbers outside of that. Okay, guys? Well, I know that was a lot. Sometimes it's a hard one. Sometimes you got to listen to it 2 or 3 times and then you just have to apply it. But there are other topics inside this series, and I hope that you found this helpful. But the totality of this playlist and the collections that we put together for you, partially on YouTube, but more comprehensively over at thisiswhy.health, helps you walk through that. If you're a program, a preceptor attending, or you're doing research and your program needs us, we offer additional services and even the ability of doing curriculum support. We have residency training programs, universities using this content around the country to teach this subject, but also for those of you doing research. So please give us a thumbs up. Maybe share some comments, experiences, additional points. Again, I know this is not fully exhaustive of everything, but the goal is to give you the core perspective and hopefully make it relevant. And we'll see you next time. Take care.